Today in this video, I am posing a question for my viewers that how fair is it to operate cataracts in this way. Now we have this patient who was a lady with a non-dilating pupil which was not responding to topical mydriatics during preoperative evaluation, and the patient had significant cataract and was to be operated for it. This is the fundus photograph, and this is the picture of the patient on the table. And this patient has been using topical mydriatics and preoperative atropine ointment usage, and still the pupil was this much dilated, and the patient's age was 87 years and she is a lady. She has no history of use of any alpha blockers, so I don't know whether this is age related or metabolic pupil which is just not responding because of atrophy of the dilator muscles. So an incision was made, and I had no plan to use any pupil dilation or stretching device, and I planned to operate her using just routine medications. When using intracameral lignocaine, the pupil didn't respond at all. I also tried injection phenocaine, which is a brand name for a solution of tropicamide with lignocaine and with phenylephrine. So this is when I am injection phenocaine into the anterior chamber to see if it can aid in the pupillary dilatation. These kind of pupil, although they may appear to be dilated to something like 4 mm just now, but it is obvious that once the surgery is going to progress, this pupil is going to go down and the pupil size is going to be something like 2 to 3 mm, which is going to make the surgery extremely difficult and at the same time risky because if it is not possible to see the contents behind the iris and an attempt is made to do phacoemulsification, there is a risk of damage to the posterior capsule and retained lens matter and vitreous prolapse. And all these things in combination make the prognosis poor for visual outcomes. The capsulorhexis has been completed, although it was a blind procedure because the progressive margin of the capsulorhexis was just not visible underneath this undilated pupil. So making a stab incision for the side port, and I use a 23 gauge MVR straight knife for the same, and now performing hydrodissection, which is again a nearly blind procedure here, and one can just simply palpate the surface of the cortex and inject fluid so as to be attempting to dissect the cortex away from the capsule. Now in this scenario it is very obvious that this is going to be a challenging surgery. Again the question arises whether this is fair to proceed with this kind of pupil, or one should stop, rethink and replan the surgery using pupillary dilatation devices. However, we'll see what happens. So this is a direct horizontal chop having a good purchase and placement of the blunt chopper underneath the rhexis, which is more or less intuitive, and performing a full thickness chop in first go. Again rotating the nucleus using the chopper and performing another chop. And recently I have switched on to create multiple chops instead of 2 chops, so as to have multiple quadrants, rather multiple pieces of nucleus available for emulsification. And here the nucleus is not very hard, although the only problem is a small pupil, which is going to be a problem as the surgery will proceed. Small pupil creates limited space, and the iris also then comes into the phacoprobe, because with the fluid flow this iris, when it is in great proximity to the aspiration port, may actually be aspirated inside the phaco tip and can get damaged. And we all know that as the iris surface is irritated more, the meiosis or the mydriasis fails and the pupils become more miotic. So the trick here is that you bring everything to the center using the second instrument and actively manipulate the pieces so as they are presented in front of the phaco-tip in the center of the pupil, and then emulsify them using a very controlled foot switch maneuver so that there is no extra fluid flow or any surge. So here you can see the nucleus has been successfully emulsified and removed, and now this is a pupil something like less than 3 millimeters. So it was a tricky surgery, and one can adopt or use pupillary expansion devices which make the pupil larger by stretching it and holding it in place. So one thing which I did was that I did counsel the patient for possibility of prolonged surgical time because of need for managing the cataract through this small pupil. Now the tricky part is that apart from removing the nucleus, the retained cortex may become an issue whenever you have this kind of situation, because the cortex, which is not visible just now, is going to get hydrated, and then later on it is going to present itself in the pupillary area or the visual axis, making the vision an issue. So it's very important that one should stretch and pull the iris away from the center so that the underlying cortex is removed, and this makes the irrigation aspiration also a very bimanual surgery. And one has to be very vigilant that you are aware of what you are aspirating. Looking underneath, making sure that none of the cortex is left behind. The surgery, the removal of the cataract has been accomplished, and now we are proceeding for implantation of a foldable IOL. This surgery is being run at 1.5 times the normal speed, just so that the interest of the viewer is retained better. So the IOL has been placed, the leading haptic goes into the bag, and the trailing haptic is properly dialed into the bag. So the majority of the task is finished, and at this moment I will again remind the viewers to put on their honest comments. What do they think? Is it fair to operate a patient for cataract with this kind of comorbidity, or one should actually increase the steps and place some pupillary expansion devices so as not to compromise the safety of the surgery? That is a question which I have left open for all my audience. So once the viscoelastic material has been aspirated out, we form the anterior chamber so that the wound is well sealed, and we will also see the next day post-op picture, and this is the next day post-op picture, and we can appreciate that there is some amount of keratitis in the superior nasal part, and rest of the pupil is still miotic in spite of use of a mydriatic agent for 1 day long, and that was cyclopentolate, and probably this pupil is not going to get very well dilated ever in future. Thank you.